numbness, an approach to a patient with numbness, which is more of a localization-based approach. Okay, when we say localization-based approach, is that um, it will try to identify which part of the nervous system is the one that is being affected, or simply put, it's answering the question, the neurological question, where is the lesion? Again, this is a very important part of neurological approach to a patient with a neurological complaint. So I have prepared this lecture so that it will become a basis for your localization later on when you go into your clinics or in the wards. So in this lecture, we will be discussing what is the first step in approaching a patient with numbness. So, in approaching a patient with numbness, we should first clarify what does he mean, or what does the patient mean when he complained of numbness, because numbness is a very vague symptom. The patient may use the word numbness to describe any alteration in sensation. This may be paresthesias or sensory loss, but also patient may also complain of numbness where in fact they are really having a weakness. Just around 2 or 3 weeks ago, we have discussed a patient in the wards that was complaining of numbness, but in fact there was no there was no sensory loss, but the patient had motor symptoms. So they were not able to clarify what does the patient mean by numbness. Or numbness can also be described to used to describe an alteration in coordination. This can also be misleading. Okay, the patient may complain of clumsiness, where in fact he is he is just complaining of the patient may be complaining of numbness, where in fact he should be saying that his arms feel clumsy. Okay, so there is problem with coordination. Okay, so first we have to clarify what does the patient mean. So therefore, the approach to the patient presenting with numbness begins with clarifying what the patient means by the word. Okay. And then the next one is we try to localize the problem. Where is the problem of the patient? Is it in the brainstem, the spinal cord, the nerve roots, the peripheral nerves? Okay, so until there lang, kasi this is numbness. If this is weakness, then it will also already involve the neuromuscular junction and the muscles. Okay, so until the peripheral nerves now. And also, we try to define the time course of the complaint. Okay, so the time course may be that of an acute numbness, a subacute numbness, and a chronic progressive numbness. So in this diagram is used best to describe the complaint of the time course of a neurologic complaint. Okay, as you can see here, this is the symptoms. Okay, and the y-axis is the times or the days. Okay, so if it is acute, it's very abrupt and it increases abruptly. Okay, there's also what we call as chronic non-progressive or a chronic progressive problem, meaning that it's very long but it is progressing. This one is a non-progressive problem. There is also a time course wherein it is an acute but recurrent problem. It waxes and wanes. Okay, and also we need to find any associated symptoms. Are there complaints of vomiting? You can see patients with alopecia. Some will have problems in their nails. Some will also have problems in their hair. Okay, so we try to do these things. We try to find out the things that are associated with the patient's numbness. Okay, so sensory information from the body travels in the peripheral nerves to the dorsal root ganglion. So this is an overview of the sensory pathway of our body. So it travels from the dorsal root ganglion to the posterior part of the spinal cord to the different types of tracts later on. We will learn these different types or tracks later on. Actually, we will start to learn them by now, okay? So sensory information from the body travels from the peripheral nerves to the dorsal root ganglion. So that's the dorsal root ganglion. Then it enters through the dorsal roots after entering the spinal spinal cord, okay? Different types of sensory information travel in different pathways towards the brain, okay? So the pain and temperature sensation travel in the spinothalamic tract, whereas the proprioception travel in the dorsal columns, okay? Okay, so there are different types of um, sensory modalities. One is pain and temperature sensation, which travels in the spinothalamic tract, and the other one is for proprioception, which travels in the dorsal columns, as you can see there in the animation. So first, let's see how the pain and temperature sensation travel. So they travel into the spinothalamic tract towards the those parts of the spinothalamic tract. So fibers destined for the spinothalamic tract cross directly. So they cross first to the contralateral and anterolateral spinal cord after entering the spinal cord and then ascend through the brainstem to the thalamus. Okay? Then the fibers entering these tracts are already destined towards the thalamus, especially in the ventral posterolateral nucleus of the thalamus, and they go into the primary somatosensory cortex, wherein this primary somatosensory cortex is also somatotopically organized. Okay, the legs are in the medial aspect while the face are in the lateral aspect. So this will become a bit different for the dorsal columns because the dorsal columns, as you can see, diba, they ascend, they go into the ipsilateral dorsal columns here, ipsilateral dorsal columns, and then they ascend ipsilaterally into the medulla, where in the medulla they uh, decussate towards the other side. And this decussation is known as the arcuate pathway. Okay, and then they ascend again into the brainstem, into the pons, into the midbrain, going again to the thalamus. Okay, and in the thalamus, they also go to the somatotopic organization of the primary somatosensory pathway. Okay, and to further complicate things, okay, the sensory pathway for the face is also different. So it is from the principal sensory nucleus of the trigeminal nerve located in the pons, and they go towards the medial lemniscus and then ascend again towards the thalamus, wherein they are again, so this is wrong, okay? They are just for the face, okay? So the thalamus is all sensory information from the extremities and torso in both the spinothalamic tract and the posterior columns, the one that we have shown in red and the one that we have shown in blue, okay, is transmitted into the ventral posterolateral VPL, this one, nucleus of the thalamus. While sensory information for the face naman is represented by the ventral posteromedial nucleus of the thalamus. So lateral is for the hands and the legs and the torso. Medial is for the face. Okay, so that's the better correction of that animation. Okay, again, it is somatotopically organized. The face is more lateral and the leg is more medial. Okay, so therefore, alteration in sensation localized to the peripheral nerves. Alteration in sensation can be localized to the peripheral nerves, the dorsal root ganglion, the nerve roots, the brainstem, the spinal cord, the brainstem, and the brain, either in the thalamus, the somatosensory cortex, or in the subcortical white matter. So this is just to provide a brief overview of the different patterns of symptoms in sensory disturbances. First are mononeuropathies and radiculopathies. So they lead to sensory loss in a specific distribution, which may be accompanied by a pattern of weakness or reflex loss related to the nerve or root affected. So these are such examples. One famous example is, of course, your carpal tunnel syndrome. This is for mononeuropathies. Radiculopathies naman, they are located in the nerve root. Polyneuropathies are different. They are symmetric. They lead to symmetric symptoms that are often begin distally, leading to a glove and stocking pattern. Okay? Spinal cord have several patterns of symptoms. They can occur from different spinal cord lesions depending on whether the lesion is a complete transection unilaterally, look, depending whether this is a complete transection, like here, okay, so this is an example of complete transection. This one is a central lesion, while this one is a hemisection naman. Okay, so later we will discuss this later. Brainstem symptoms can be classified as being, they are uncommon, but they usually have a cross finding. Ipsilaterally located in the face, while contralaterally in the body. This is far different from a thalamic, subcortical, or cortical lesion, wherein there is complete contralateral sensory loss that affecting the contralateral part. Okay, so those are the different patterns of symptoms. Don't worry, this is just an overview. Later, we will be discussing the different patterns of weakness. Patterns of sensory disturbances. Okay, so neuropathy refers to the pathology of one or more peripheral nerves. So the symptoms depend on the fiber type affected. So whether they are sensory fibers, motor fibers, or autonomic motor fibers, or even combination of the three. So sensory symptoms may include negative symptoms such as loss of sensation, while positive symptoms naman for paresthesias and pain, or they may be both. Okay, so sensory loss can be multimodal or specific to a different modality. So this, when we say mode of modality, this can either be pain and temperature, the one that we have discussed kanina, or vibration and proprioception. Diba? Remember, pain and temperature is for the spinothalamic tract, vibration and proprioception is for the dorsal column. So we have to be very specific. So I will emphasize to you, you have to be very specific about the sensory modality that you are testing. This may be pain and temperature or vibration and proprioception. Proprioception. So when you say pain and temperature, you try to do pinprick with a needle, or you try to do ice pack. You try to run it on the patient's skin. So this is testing for pain and temperature. For vibration naman, it's for you use the tuning fork, okay, to elicit a vibratory sense. And for proprioception, di ba? That's for testing the joint position sense, okay? So these are different modalities. So we have to be very specific, okay? So uh, a while back was the brief overview. This one is we will try to tackle the different patterns of symptoms. Okay, first is mononeuropathies. Mononeuropathies happen when a single nerve is affected. So symptoms occur in the distribution of that particular nerve. So these symptoms may involve either sensory or motor disturbances. Okay, so mononeuropathies are most commonly caused by trauma or compression, because the most common mononeuropathy is the compressive mononeuropathy, which is carpal tunnel syndrome. Okay, so there, this one is a patient with carpal tunnel syndrome. So aside from carpal tunnel syndrome, which is a mononeuropathy of the median nerve, other mononeuropathies could involve the suprascapular nerve, wherein the patient can feel pain pain radiation on the shoulder, and compression may also cause atrophy of the supraspinatus and the infraspinatus muscle. For the musculocutaneous nerve naman, this will be the area of hypesthesia or numbness, and there will be weakness of elbow flexion. So this one naman is for the long thoracic nerve. The long thoracic nerve is really a muscular motor nerve, not not really that of a sensory nerve. Okay, so these are the other signs of carpal tunnel syndrome. It can be associated with different conditions such as pregnancy, endocrine disorders, rheumatoid arthritis, sarcoidosis, hemodialysis, and amyloidosis. But the most common in most of the cases, it can be idiopathic. This is related to repeated stress, just like in driving. Okay, so these are the different. So this is the pattern of sensory disturbances in the um, palmar aspect of the lateral hand, okay, involving the thumb, the index finger, and the middle finger. Okay, so most commonly, patient awaken with tingling sensation, and there can be atrophy of the muscles. Okay, so how do we assess this? We do provocative tests such as Phelan test, and we also can do Tinel sign. Okay, digital compression test, you can do this, but again, sometimes carpal tunnel syndrome appears bilaterally. Okay, so non-surgical management will involve splinting and also steroid injection. While we can surgeons or orthopedic surgeons can do uh, decompression of the carpal tunnel. Okay, so there. This one naman is a manifestation of a patient with ulnar tunnel syndrome. Okay, so not really a tunnel, not really a anatomical tunnel, but just to compare it with the carpal tunnel syndrome. So this is an ulnar nerve mononeuropathy, which will involve the ulnar area. And most of the time, this is due to yung mga nagbabike, okay, doing bicycle. Okay, because they have repeated compression and trauma of the ulnar nerve. So this one naman is in another ulnar nerve mononeuropathy, but this time due to the uh, ulnar nerve being compressed at the cubital tunnel. So what the same pattern of weakness, but the localization is far above in the ulnar cubital tunnel. Okay. So this one naman is a radial nerve mononeuropathy, can be due to a what we call this as a Saturday night palsy. A person who is drunk on a Saturday night sometimes will lay their hand over a chair, and this will result into a mononeuropathy. So the manifestations are the following: wrist drop and unable to do the weakness of the posterior interosseous syndrome. So that's for mononeuropathies. Those are just the common mononeuropathies. But sometimes, or even most of the time, the patients may complain of polyneuropathy. So the clinical presentation and differential diagnosis of symmetric polyneuropathy was discussed a while back, and most polyneuropathies are chronic, and although they may be present in the hospitalized patient, they are unlikely to cause hospitalization, hospital admission. Okay, so again, as mentioned, they are chronic, usually symmetric in distribution, and has a stocking glove pattern. So these peripheral or polyneuropathies will have numerous possible causes. They can be hereditary, idiopathic, inflammatory, infection, even due to malnutrition, metabolic, and even toxic uh, substances can cause polyneuropathies. So how do we go about in approaching these patients with polyneuropathy? We need a simplified approach to characterize the polyneuropathy. So we ask this four simple clinical question: what, where, when, and what setting. Okay, so the what refers to the nerve fiber modality. Again, it's about the nerve fiber modality. Is it a motor, a sensory, autonomic, or combination of the three? Okay, so for sensory symptoms, if patients have sensory symptoms, then we may already exclude neuromuscular diseases which are not associated with sensory dysfunction. So these diseases will include ALS, neuromuscular transmission, and myopathies. So um, we also need to classify whether the sensory symptoms are positive or negative, di ba? We have discussed the positive or negative symptoms a while back. Positive symptoms may be that of a burning, freezing, or throbbing sensation, even tingling or swelling sensation. These positive symptoms will suggest an acquired etiology, just like GBS, diabetic neuropathy, CIDP, alcoholic, or uremic neuropathies. Negative symptoms, on the other hand, naman, are examples of which are loss of sensation and or sensory action. So, as negative symptoms will likely suggest hereditary, but not all the time. Okay, most of the time lang they suggest hereditary causes. Okay, so we have discussed this. So these are the different types of painful polyneuropathies. Okay. So for still in the question of what, okay? So again, 'di ba, we have discussed the modality. This can be either motor or sensory. For the sensory, we have discussed whether this is a positive symptom or a negative symptom. Now we go to the autonomic nerve involvement. So there are only a few neuropathies that will affect both autonomic and somatic nerves, meaning the autonomic nerve system, and the sensory nerve system, sensory and motor nerve system. These are Guillain-Barré syndrome, paraneoplastic neuropathies, diabetic neuropathies, and amyloid neuropathies. So what are these autonomic symptoms? This can either be due to lightheadedness, syncope, diarrhea, uh, or even erectile dysfunction. So these are the most common, especially for men, are orthostatic hypotension. So meaning on sitting down, their BP is adequate, but upon standing up, their BP drops. Okay, and also we should ask about the history of erectile dysfunction. So we can know if there will be involvement of the autonomic nervous system. Okay. And then after asking the what question, we now ask the where question, meaning the distribution of the nerve damage. So we determine whether it's a length dependent. When we say length dependent, uh, the distal extremities are affected first, then the proximal extremities. So the leg is affected first before the thighs. Okay, so length-dependent neuropathies manifest first in the feet and are symmetrical. So if this is a length-dependent neuropathy, this can either be an inherited cause, metabolic, toxic, or idiopathic. Okay, for patients with infectious causes or immune-mediated causes, these are usually non-length dependent. And then when, of course, diba, we have discussed in the first part of our lecture the time course or the temporal profile, whether this is an acute, subacute, or chronic symptoms. Okay. Kasi for acute onset, this might be infectious or immune-mediated. For chronic onset, this can be inherited, idiopathic, or metabolic. But mind you, the pace of progression is also important. Okay. And then, what setting? So this refers to the clinical circumstances of the individual. So this is where your past medical history, medication history, social and personal history, and even your family history will come in. Okay, you ask whether there's a history of diabetes or even alcoholism, or even you ask if there is a past medical history of kidney problems, or even medication history because some medications like isoniazid, disulfiram, vincristine, hydralazine, and other medications can cause neuropathies, polyneuropathies. And also, again, you ask different past medical history. Is this associated with vomiting? Any anti-copper utensils that the patient may be using? Associated symptoms, just like uh, problems with his hair and in the nails, okay? Because this might, we might diagnose arsenic poisoning or even alopecia. Okay, so these questions are also important. Okay, an additional step may be used, which is using already your uh, EMG, NCS, electromyography, and nerve conduction study. So this is a machine that will now look into the muscles with electromyogram and nerve conduction studies stimulating the nerves in order to know the health of these nerves. So this is considered as the fifth step of characterization and can contribute to the what, where, and when of characterization. It can also further classify whether this is an axonal polyneuropathy or a demyelinating polyneuropathy. Okay? So that test can help in diagnosing polyneuropathies. But sometimes some neuropathies can be non-symmetric and does not follow a glove and stocking pattern. This can be referred to as mononeuropathy multiplex, wherein there is a sequential involvement of individual nerves. So, for example, the radial nerves are affected first, followed by peroneal neuropathies. This is most of the time systemic vasculitis can be due to leprosy, hepatitis C, or even HIV infection. So for radiculopathies, radiculopathies typically cause radiating pain from the neck or back into the distribution of an individual nerve root. So this can be accompanied or may be accompanied by paresthesia, sensory loss, and or weakness. This compression due to degenerative disc disease is the most common etiology for radiculopathies. Sometimes polyradiculopathies can also be caused by local compression or invasion of malignancies, just like Lyme disease, CMV, and CMV radiculitis for patients with HIV infection. After radiculopathies, plexopathies, di ba? Plexopathies are what you learned in your neuroanatomy, di ba? When you learn about the uh, brachial plexus, the lumbar plexus, and the lumbosacral plexus. Okay, so most of the time, uh, plexopathies are unilateral sensory symptoms, and they do not fit the distribution of a single nerve or even a nerve root, spinal nerve root. Okay, so this is where the possibility of a brachial or lumbosacral plexopathy should be considered. But most of the time, motor features predominate over sensory disturbances in these plexopathies. Okay, so these are examples of plexopathies, can be due to a problem at birth or even mastectomies or even trauma can cause these plexopathies. Okay, tumors also can cause lumbosacral plexopathies. Gangliopathies are not that common, but they refer to the disease process affecting the dorsal root ganglia. So the uh, manifestation is usually, or the distribution is usually the same as that of the spinal nerve root involved, but what is more prominent is that in these ganglionopathies, the reflexes are absent. Okay, and the strength is usually spared. Next is spinal cord. So this is the last sensory patterns of symptoms, which is the spinal, one of the last, sorry. But I think one of the most important sensory patterns of symptoms in sensory disturbances with the spinal cord. So this spinal cord lesion can cause deficits below the level of the lesion, and the type and extent of deficits depend on the location and size of the lesion. This can either be due to trauma, vascular infection, or inflammatory conditions. The most important or the most useful clinical sign of spinal cord pathology is finding what we call as the spinal level or the spinal sensory level. This is a level on the back of the patient or even in front at which there is a change. There appears to be a change in sensation with diminished sensation below the level and preserved sensation above the dermatomal level. So here is what an example of lost spinal level. Okay, so the doctor is testing the pinprick modality, the pain and temperature sense modality on the patient, and he notes that there is a change of sensation in this dermatomal distribution and below. Okay, so there's preserved sensation on above this level, and there is decreased sensation below that level, on that level and below. Okay, so this is for complete transaction. So for complete transaction, there's a full thickness lesion of the spinal cord and complete paralysis and sensory loss in all modalities below the level of the lesion. This can either be due to an acute cause, which is trauma, or transverse myelitis. Sometimes this can be the pattern of distribution can be on the arms only, okay? And this can be attributed to a central cord syndrome. So central cord syndrome is usually due to the enlargement of the central canal, which is called a syrinx, okay? This is commonly located at the cervical level. Most of the time, this is caused by spinal cord tumors, spine trauma, and Chiari malformation type 1. One of the most fascinating distribution in neurology is the Brown-Séquard syndrome. So the Brown-Séquard syndrome or hemi section of the spinal cord, there is ipsilateral paralysis, ipsilateral loss of proprioception, and contralateral pain and temperature loss below the level of the lesion. So there's only contralateral pain and temperature loss below the level of sensation. Kasi di ba, when you recall, it is the spinothalamic tract or the modality for pain and temperature sense. And after the dorsal root ganglion, they enter the spinal cord and immediately decossate. For the proprioception, di ba, they are located ipsilaterally. Another pattern of symptoms in the spinal cord is what we call as anterior cord syndrome, wherein there is infarction of the anterior spinal cord, anterior spinal artery, because the anterior spinal artery is responsible for perfusing the anterior part of the spinal cord, this part. Okay, so there will be paralysis, bilateral paralysis, and bilateral loss of pain and temperature sensation, but with preservation of the proprioception and vibratory sense. Okay? As mentioned kanina, brainstem, usually rare, but they will cause a cross-sensory loss. Okay? Ipsilateral to the face, contralateral to the body. Most of the time located in the lateral medullary area. So, but for patients with trigeminal nerve problem, usually caused by skull-based lesions, can be due to inflammatory, some head and neck cancer and dental pathologies can cause facial numbness. Okay, either in the V3, V2, or V1 distribution. But most commonly, this can be a problem on the third part or the maxillary part of the spine of the trigeminal nerve. Okay, for brain lesions that causes sensory disturbances, this is usually due to this usually manifests in a specific part. Okay, or hemisection. Okay, ipsilateral, both for the face and for the body. This is usually due to a lacunar infarction of the thalamus. And these are other possible causes. Okay? But some causes can be non-neurologic, and this can be due to hypocalcemia or even hyperventilation can cause these problems. So this is a good approach to a patient with numbness. Is it unilateral, bilateral, and these are the possible areas. So see here, if it is unilateral and one limb only, this can be your differentials. Okay, so that's the last part of our lecture. Do you have any questions?
No, no,
No question. No questions.
no question.
Okay. So if you don't have any questions, I will just give your slides. I will just give the slides to Kulvan, and Kulvan, can you distribute it to your classmates? Okay.
Okay, doc.
Thank you for listening and have a good night.
Thank you, doc.
Thank you, Doc.